Hi, my name is Sammy, and today we'll be looking at the Gabriel Feeding Tube with Balloon by Synchro Medical Innovations. For the company introduction, Synchro Medical Innovations was founded in Macon, Georgia by Dr. Gabriel, the inventor of the Gabriel Feeding Tube. The company was restructured in 2012 and receives the majority of its funding from NIH and DoD grants for product development. For the product introduction, this is a novel enteral feeding device with essentially four unique features. The first feature is that it has a balloon at the distal end that promotes post-pyloric migration using the body's natural peristalsis. Essentially, when the tube is placed into the stomach and the balloon is inflated, the waves of peristalsis will grasp onto the distal end of the balloon, similar to how the body would advance a bolus of food through the intestines. So, the waves of peristalsis will catch the balloon, advance it through the pylorus, and migrate the tube distally into duodenum and even into the jejunum. This allows for a simple placement procedure, and so any nurse who can place an NG tube can place the Gabriel feeding tube, as essentially we're just placing it into the stomach, and peristalsis is doing the rest. The second and third unique features of the Gabriel feeding tube are designed to reduce the risk of pneumothorax. The sheer size of the inflated balloon will prevent deep advancement into the lungs in the event of an inadvertent tracheal misplacement. When the balloon is inflated, because of its size, it won't pass through the rigid cartilaginous bronchi of the lungs, and it won't be able to reach the softer tissue of the lung that can be punctured and lead to a pneumothorax, which is a serious complication of feeding tube placement. The Gabriel feeding tube is also equipped with an end-tidal CO2 sampling line. The purpose of this is to sample the air environment at the distal end of the tube and will also indicate misplacement into the lungs if we detect end-tidal CO2, which is produced by the lungs but should not be produced by the GI system. The fourth unique feature is the wire-reinforced wall. The purpose of this is to prevent kinking. This also reduces the risk of clogging and allows for the additional slack to be placed in the stomach, giving the Gabriel feeding tube the potential to migrate post-pylorically using the body's natural waves of peristalsis. The product comes as a complete kit with everything that you'll need for a bedside placement of the device, and this can reduce the time spent running to collect the needed items for placement procedure. The kit contains the instructions for use with pictures, as we'll go through in the next few slides, benzocaine numbing gel for patient comfort, lubricant gel for the insertion procedure, a silk suture thread for a unique placement procedure that we'll detail in the next slide, a butterfly adhesive nasal securing strap that can be alternated with a bridle, depending on your institution's preference, a 10cc syringe, the Gabriel feeding tube with balloon, which is available in both ENFit and the standard connections, and also the end-tidal CO2 line with connector that we discussed. Moving on to the insertion procedure. We'll begin by selecting a nostril and applying the included benzocaine numbing gel. Analgesia should take approximately 2 minutes. While we're waiting for this to occur, we can go ahead and take our end-tidal CO2 sampling line and connect it to the proximal stylet hub of the feeding tube and also to our vital signs monitor. Also, while we're waiting, we can apply the lubricant gel to the distal end of the device and also insert a silk suture thread that's included through the side hole and distal hole of the feeding tube tip. You can see it already inserted in the picture in figure 1. Basically, you'll take the silk thread, insert it through the side hole of the feeding tube, pull it out of the distal hole, and then you'll have both strands attached to the distal end of the feeding tube, as you can see in figure 1. At this point, 2 minutes should have passed and we're ready for our insertion procedure. We'll go ahead and take the feeding tube and insert it directly posteriorly into the patient's nasopharynx. While we're inserting it, we'll pull towards ourselves at the 6 o'clock position, grasping both ends of the silk suture strand that we inserted into the feeding tube tip. This will cause the distal end of the feeding tube to deflect downwards towards the patient's oropharynx, allowing us to successfully navigate the turn of the nasopharynx with minimal trauma to the posterior nasopharynx. This is also a useful technique in patients with limited cervical flexion and extension. You can continue to advance the feeding tube until you feel a decrease in resistance, indicating that you've successfully reached the oropharynx. At this point, you can pull on one end of the silk suture thread, removing the thread, and it can be discarded. We'll continue the placement procedure by inserting to the 18 centimeter is at the nostril. At this point, we'll ask the patient to swallow. This will help to direct the feeding tube towards the esophagus rather than towards the trachea. We'll then continue to advance the feeding tube until the 30 centimeter mark. At this point, we'll need to determine whether we're in the esophagus or in the trachea. We'll do this by inflating the balloon. In the conscious patient, this should cause a strong cough reflex. In patients with a weak cough reflex, or patients that are sedated or unconscious, we can use our end-tidal CO2 sampling line to make the determination of proper esophageal placement or tracheal misplacement. We'll do this by looking at our vital signs monitor. With the balloon inflated, we'll look at our vital signs monitor, and if we're in the trachea, we should see waveforms in the yellow line as seen in the cutout at the top of figure 3. These waveforms represent CO2 that's produced by the lungs and correlate with the patient's respiratory rate, indicating tracheal misplacement. With successful esophageal placement, you should see a flat line on your end-tidal CO2 monitor as seen by the yellow line on the cutout at the top of figure 4. This is because no CO2 is produced by the gastrointestinal system, so we shouldn't see CO2 produced if we're correctly inserted into the esophagus. Again, if you see CO2 and waveforms correlating with the patient's respiratory rate, then we know that we're in the trachea and we'll have to restart the placement procedure from the 18 centimeter mark. With a flat line on end-tidal CO2, we know that we're correctly in the esophagus. Additionally, we can also reference pulse oximetry. If there's a drop of 5 points on pulse oximetry after 2 minutes after placement, this would indicate tracheal misplacement as well, and the tube should be taken back to the 18 centimeter mark and reinserted from this point. Now that we've determined the tube is correctly inserted into the esophagus, we can continue inserting until the 70 centimeter mark. At this point, we'll begin to remove the stylet and advance the feeding tube over the stylet till the 100 centimeter mark. This will accomplish the goal of collecting slack into the stomach to give the tube potential to advance postpylorically. At the 100 centimeter mark, the stylet can be completely removed and the feeding tube can be secured to the patient's nose using the included adhesive strap or a nasal bridle. This completes the placement procedure. Figure 7 is an optional step where 60 cc's of warm water can be infused through the feeding port to stimulate the body's natural peristalsis to promote postpyloric migration. We also recommend obtaining a post-placement KUB to indicate proper placement prior to initiating feeding, as this is most institutions' protocol. You can see in the left x-ray in figure 8 that the tube is coiled in the stomach with the balloon inflated. The next x-ray on the right is taken approximately 12 hours after placement. You can see that the feeding tube has migrated postpylorically through the duodenum and deep into the jejunum with the balloon still inflated. We'll show a few more examples of this in the next few slides. Again, you can see the feeding tube coiled in the stomach here with the balloon inflated, and it's the wire-reinforced wall that allows us to insert this slack into the stomach without kinking and initiate early gastric feeding with postpyloric migration potential. And then 12 hours later, you can see that the feeding tube tip is approximately at the ligament of Treitz. Here's another example with the feeding tube coiled in the stomach, and the next morning it's advanced deep into the jejunum. To reiterate a few of the product's key points, we discussed the distal end balloon that promotes postpyloric migration by peristalsis and allows gastric placement of the feeding tube with a high potential for postpyloric migration. Also, the distal end balloon prevents advancement deep into the lungs, which also reduces the risk of pneumothorax. The balloon also allows us for accurate end-tidal CO2 detection using our end-tidal CO2 sampling line, which indicates tracheal misplacement and early detection of tracheal misplacement, reducing the pneumothorax risk as well. The wire-reinforced wall prevents occlusion by kinking, and although it's wire-reinforced, it's tested for use and safe for use in 1 in 3 Tesla MRIs, which are the most common MRIs in large hospitals. We discussed the distal hole that allows for downward deflection of the tube during insertion, decreasing trauma to the posterior nasopharynx. I've included our publication, which was recently published in February of this year in Critical Care Nursing, detailing our postpyloric placement rates and tracheal avoidance techniques. In this study, we had a postpyloric migration rate of 70% already at the next morning after placement, and we successfully detected tracheal misplacement in a single patient using pulse oximetry after the balloon was inflated. This concludes our presentation. I've included our contact information as well as our website and ordering information. Thank you for your attention.